Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Heart Valve Reoperations. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com over 15 years ago. And the mission of our website is real simple. We want to educate and empower patients just like you. This webinar, which has had registration from over 730 people around the world, was designed to support our mission. Now, throughout the webinar, you're going to be in what's called listen-only mode, but I encourage you to submit your questions in the control panel that's up on your screen, and I'll explain why. As we look at the agenda, we're going to introduce the featured speakers. We're going to talk about heart valve disease and overview and treatment options. We're going to look at some of the latest and greatest reoperative techniques, including this idea of valve and valve, and is it the end of surgery? We're going to have a wonderful patient spotlight, and then I'm going to ask you to complete a very quick 5-question survey at the end of the webinar. Now, for the featured speakers, it is a gift that we're going to be talking to Joy Marks, who is 80 years young, from Chicago, Illinois. She's been a teacher for over 30 years. She enjoys dancing, yoga, and walking. In 2014, specific to this conversation, Joy had a surgical mitral valve replacement. Then just recently, a few months ago, she had a mitral valve in-valve reoperation using transcatheter techniques. And we're going to talk to her all about her experience. But Joy, thanks for being on the line with us today.
You're welcome.
And now let's talk to the physicians. And I am honored that they're taking time away from their very busy practice at Northwestern Medicine. We are thrilled to have Dr. Charles Davidson with us today. He's the professor of medicine, clinical chief division of cardiology at Northwestern University Feinberg School of Medicine. He's also the medical director at the Bloom Cardiovascular Institute at Northwestern Memorial Hospital. He is a clinical trial specialist, and he's done work on some of the largest, most transformative valve clinical trials, including the PARTNER trial, EVOQUE, EARLY TAVR, PASCAL, and REPAIR MR, and many more. He's a consultant too and receives grant support from Edwards Life Sciences. We are also happy to welcome Dr. Christopher Mehta, who's an attending cardiac surgeon at Bloom Cardiovascular Institute at Northwestern Memorial Hospital. He's the assistant professor of cardiac surgery at Northwestern University Feinberg School of Medicine. He specializes in minimally invasive complex surgery, including TAVR, transcatheter aortic valve replacement, and valve-in-valve procedures. He has a focus on aortopathy, including root repair and replacement of things known as aneurysms. He's a consultant to W.L. Gore and Associates. Dr. Davidson and Dr. Mehta, thanks so much for being with us today.
Pleasure to be here. Thanks, Adam.
Thank you, Adam. Appreciate that.
And so I could go on and on all about the achievements of Dr. Davidson, Dr. Mehta, and the entire team there at Northwestern Medicine. What I'd like to do, though, is show you this. You might see all these smiling faces on the screen in front of you. These are patients in the HeartValveSurgery.com community who have gone to Northwestern Medicine and had care, wonderful care, excellent surgical outcomes, excellent interventional outcomes from folks like Dr. Davidson, Dr. Mehta, and the entire Northwestern team. And it's great to be and know these people and see how they're smiling in these photos. So with that said, I'd like to welcome this wonderful group of people, Joy, Dr. Davidson, and Dr. Mehta. And now we're going to kick it off. And I'm going to pass the slides over to Dr. Mehta.
Thanks, Adam. Let me just start with an overview of anatomy and kind of what we're talking about here. So at a real basic level, heart valves control the direction of blood flow through the heart. There are 4 valves. We're going to focus on these 3 because these are the ones that we most commonly see disease in. So on the right side of the heart is the tricuspid valve, which is between the right atrium and the right ventricle. And then blood goes from the right ventricle to the lungs. comes back on the left side of the heart in the left atrium. And then the mitral valve sits between left atrium and left ventricle. The left ventricle then ejects blood through the aortic valve into the aorta, where we get blood to our brain and our organs, the rest of our body. Next. And so you could have two major issues with heart valves. One being a narrowing of the valve, also known as stenosis, where the leaflets do not open fully and it limits blood going through that valve. The other issue is regurgitation, which is also known as leakiness of the valve. And that's where the leaflets may not necessarily close onto themselves together. And so blood can flow backwards. And the aortic, mitral, and tricuspid valve can all experience one of these two. And when we're thinking about treatment options, there's a lot to consider: age, the complexity of what's going on, and the overall degree of these two issues. You can click next. And so when we look at aortic disease in particular, aortic stenosis, again, is that narrowing of the aortic valve. And what can happen is it can cause the left ventricle to be working really hard to pump blood across a narrowed valve. So then there's a higher pressure in that left ventricle, and it compensates by actually thickening. The heart's a muscle, so it'll get thicker and stronger, but eventually it can only do so much. And then it leads to a weakening of that muscle, which can develop into heart failure. So common symptoms here are shortness of breath, chest pressure, lightheadedness, sometimes even fainting. And we're going to talk about this a little bit more, treatment options here, but it basically falls into the realms of either surgery or transcatheter aortic valve replacement. And a lot of this does depend on age. So younger folks tend to get a surgical option. And then, as we get older, especially older than 70, we tend to prefer a transcatheter aortic valve option for those patients. The other issue is regurgitation, that leakiness through the valve. This can happen, as we say, acutely, meaning all of a sudden, or it can be chronic, meaning it happens over a long time. Once it's severe, you typically need some form of intervention. And again, symptoms are quite similar: shortness of breath, chest pressure, you could have lightheadedness. Now, here, our treatment options are more in the realm of surgery. Sometimes we can repair the valve surgically, sometimes we replace it. There are some transcatheter options currently in trial, but again, the mainstay for now, at least, is surgery. Next.
And Dr. Mehta, for some of the patients out there who might be newly diagnosed, they're seeing this term mini thoracotomy.
Yeah.
Can you explain to the patients what that might be compared to a traditional sternotomy?
Sure. So, traditionally this was done with a full breastbone incision, where we go through the full breastbone. We've had advances in techniques in surgery the same way we've had advances in transcatheter. And so now we have more minimally invasive options for replacing the aortic valve. And I'd say, at least at Northwestern, we tend to do more of the minimally invasive options, such as mini thoracotomy, for example, where we actually just go between the ribs. So we don't even need to go through the breastbone. Another option is a partial or mini sternotomy, where it's a partial breastbone instead of the full breastbone. So we have some, more minimally invasive options, quicker recovery, that sort of thing.
Great, thanks so much.
Now, when we talk about mitral valve disease is the most common form of heart valve disease in the US. And again, we're talking about mitral regurgitation, leakiness, where blood backs up into that left atrium we talked about. Again, the left atrium kind of accommodates the increased blood volume to some degree, but eventually, you can develop symptoms of shortness of breath, fatigue, fluttering heartbeat, also known as atrial fibrillation, chest pain. Stenosis is that opposite problem, where it's a narrowing of the valve, where you get decreased blood flow to the left ventricle. And then fluid can build up in the lungs. It can lead to, again, sort of a backup, if you will, of blood to leading to shortness of breath and other sequelae of that. Now, for these, we have surgery and transcatheter interventions as well. And these typically come after we've sort of exhausted medical management and once those diseases get in their more severe form. Mitral valve prolapse now falls sort of in the realm of the mitral regurgitation. And, this is sort of a misalignment of the leaflets, if you will. And again, once it gets to that severe range, people tend to feel it and you tend to need to do something about it. So in terms of treatment options, very broadly speaking, we have two types for all those valves. One is transcatheter valve replacement. And this is where we're able to insert a wire into an artery or a vein, a blood vessel. And then under live X-ray, we can put that wire across the valve, and then we can sort of insert a new valve within the native diseased valve. And so this is more minimally invasive. The surgical valve replacement is open heart surgery. It requires cardiopulmonary bypass, the heart-lung machine. And this is where a surgeon can physically remove the diseased valve and replace it with either a mechanical or a biological valve. And we'll talk about that in a little bit. Okay, so we focus on this a little bit. These are the options for surgical valve replacement. Sternotomy means a full breastbone incision. And again, we're doing a lot of more minimally invasive options now. So that picture you see on the right, that's what would be called a partial sternotomy or a mini sternotomy, where we just have to go through part of the breastbone, not the whole thing. Down in the bottom right, we have also a right anterior thoracotomy. That's also known as that mini thoracotomy approach, where we can go through the between the ribs. And so these incisions are about 4 or 5 centimeters. They're not as bad as the conventional traditional sternotomy. Next. So why do replaced valves fail? This is a question very germane to this particular webinar. And now when I counsel patients on surgical valves and the type of valve to choose, there are pros and cons to both. So let's start with the mechanical valve. Now, mechanical valves are made of certain carbon compounds, titanium, and the benefit of the mechanical valve is that it often will last the rest of the patient's life. Meaning, once you place it in theory, you should not need surgery ever again. The downside is that you need blood thinners in order to get a mechanical valve, all right? Because if you don't have blood thinners, the valve can form clots on it, and it can make it not work. Now, I say in theory, the patient may not need surgery in the future, because from time to time, very rarely, we do sometimes see patients who need a replacement of a mechanical valve. That tends to be more for issues like infection and less because the valve itself is failing. Now, the other option is a bioprosthetic valve. These are typically made from animal, so cow or pig, sometimes human tissue. Now, compared to mechanical valves, you don't need long-term blood thinner anticoagulation, so that's good. The downside is they have a certain durability, longevity to them. And so it depends if it's aortic versus mitral versus tricuspid, but typically we're speaking about 15 years or so from surgery. And so then you need to think lifelong, what's going to be the next option, for example. And much like aortic stenosis or regurgitation of those valves, the tissue valves can also eventually degenerate as well. So again, you sort of need to plan in the future what's going to be the next step after we place a tissue valve. Now let's talk about transcatheter aortic valve replacement, also known as TAVR, because over the course of the last 2 decades, we've really made tremendous strides in this minimally invasive technology. So the first TAVR was, the first in-human TAVR was performed in 2002. And both balloon expandable valves and self-expanding valves underwent clinical trial. First in patients who are high risk and inoperable, followed by intermediate risk, followed by low risk. And so now we have FDA approval actually for all ranges. That is patients who are low risk, to patients who are even high risk and inoperable for both the commercially available valves. And so I alluded to this earlier. We need to know the longevity of the valve with respect to the patient's age and comorbidities, because anytime we're implanting a valve, we need to think, well, what may be the next step in the future, right? So if a patient is a low surgical risk, and especially if they're on the younger side, we tend to favor surgical valve replacement in those patients with an understanding that they may, in the future, if they need it, can get a valve-in-valve procedure, which we'll talk about. Older patients, maybe patients at higher surgical risk who may struggle with surgery, transcatheter may be a better option there. And so this is where valve-in-valve comes in. Now, valve-in-valve, that term implies that there is a previously implanted valve, and we're placing a new valve within the failing previously placed valve. All right. And so, what you see here on the left is an aortic valve prosthesis, a patient who's gotten a surgical aortic valve. And then on the right, a patient who's had a previous surgically placed mitral valve. And so with valve-in-valve, transcatheter, meaning a wire across that valve, we can place a new valve within the old valve once it has failed. And so the question becomes, well, who is a candidate for valve-in-valve? And there's no straightforward answer here. It's a nuanced thing, which is why Dr. Davidson and I and our interventional cardiology and surgery colleagues meet in a heart valve team multidisciplinary meeting to review everybody's cases and see who would be a candidate for valve-in-valve versus who we think may be better served with a reoperation surgery. And so there are a few things to take into consideration here: age, surgical risk, the symptoms a patient is having, and perhaps more importantly, the anatomical findings that we're seeing on echocardiogram and on CT scan, because a lot of that tells us whether a patient may be better served with valve-in-valve versus a patient who may just need a second reoperation now with an anticipation of a valve-in-valve in the future. This is the valve-in-valve device landscape currently, and in particular for the aortic valve. So we have the Edwards balloon expandable valves and the Medtronic self-expanding valves. They've gone through different generations, and the valve technology keeps improving, and so we're seeing better and better results with valve-in-valve. Next.
And Dr. Davidson, for patients, and I'm actually curious to know about this, when you talk about the Edwards valve versus the Medtronic valve, one expanding, one I think you said self-expanding. What does that mean?
Yeah, and it's a good question. The balloon expandable are those four across the top, and basically it's made of a metal that needs to be expanded with a balloon. They used to be stainless steel, now they're cobalt chromium frames. As you can see, it's a slightly smaller footprint, if you will, and the valve material, which is bovine pericardium, is mounted inside of that, so it becomes an annular type of valve. The self-expanding means that once you release the valve, it's made of a nitinol metal that expands on its own, and its dimensions are calculated for both of these valves based on CAT scans that we obtain with the patients ahead of time. The Medtronic valve is made of porcine or pig pericardium, and it's a superannular valve, so not at the annular level, but you can see that it's a little bit larger footprint, but it's just a matter of what type of metals that are used and then how they anchor to the native valve, or in the Medtronic situation, also to the aorta.
And is it dependent upon, I'm guessing, I don't know, the patient's anatomy, that you might prefer to use one valve over the other? Or is there some other criteria that you use to help you figure out which valve to use?
Yeah, it's probably the subject of an entirely full hour, but there are reasons to pick one over another. Some are local choices where certain centers prefer one over another. There are data to suggest that maybe one is preferable in certain circumstances than another. I guess I would encourage the people to have this discussion with their cardiologist and cardiac surgeon to understand what might be the best valve choice for them. Just like anything, that's not one size fits all, not one product suits all. And so anatomy is certainly a key factor in valve selection.
Great, thanks so much.
So as far as access for doing a transcatheter procedure, we typically prefer to go through the artery in the groin, which is the femoral artery. So most of the time, that's the approach we'll take to get a wire around to the heart. Sometimes we can't do that due to anatomical reasons. And so we have a number of other options that we can use as well. For example, sometimes we go through the carotid artery in the neck. Sometimes we make a small incision in the chest between the ribs. And then sometimes we can actually go through the upper portion of the aorta itself. So we have a number of different options in case we can't go through the femoral artery. And then this is an animation that's going to show you how we perform a valve-in-valve procedure through a femoral artery approach, the artery in the groin. So the first thing is we place a wire from the femoral artery around through the previously placed aortic valve that you can see on the screen into the left side of the heart. And then we bring a valve that's mounted onto a balloon around into place basically where the previous valve was. We have a temporary pacemaker in the heart with which we could use to pace the heart. And that allows us to deploy the balloon and put the new valve within a valve. So it's sort of like a stent. And then we take everything out. So you can see in this image, the new valve has actually pushed the old valve leaflets out of the way, and now it's working as the new valve. So this is called valve-in-valve. And so when talking about valve-in-valve transcatheter procedures for aortic and mitral valves, the benefits here are that you don't have to go back in the chest, right? It's not an open chest operation. It doesn't require the heart-lung machine cardiopulmonary bypass. And so it tends to lead to shorter recovery times, less blood transfusions, less incidence of post-operative irregular heartbeats, including atrial fibrillation. There are still risks, of course, and this is not for everybody. We always review in a multidisciplinary fashion whether a patient would be a candidate for this kind of procedure. For one, the previously placed valve is not removed. We're pushing the leaflets out of the way. We are using major blood vessels, including the femoral artery, and we're putting wires in the aorta. So we do have to be cognizant about bleeding complications that can occur, although they are not frequent. And then anytime we're looking at previously placed valves, we worry about a leak around the new valve called a perivalvular leak. So these are just some of the considerations we have when assessing somebody for a valve-in-valve procedure. These three frames demonstrate a mitral valve-in-valve for a patient who's had a previously placed, surgically placed valve. And so similar concept here, we're placing a wire through a blood vessel and across the previously placed valve. Next, we bring in the new valve in the second frame over a balloon. And then when everything looks good, we inflate the balloon, which then leaves the new valve within the old valve and functions as a new working valve. And so these are images from an echocardiogram looking at how well the valve is functioning. And so before the intervention, the gradient, the pressure gradient across the valve is high. That number 15 is pretty high. And you can see after the intervention, it comes down to a more normal appropriate number, meaning that the valve is working better. This is a three-dimensional echocardiogram, which is just showing how the leaflets of the new valve open. So, you get a good sense that it's working well here. And then this is an aortic valve-in-valve procedure. So if you look at the frame on the left, that crown-shaped thing is the previously surgically placed aortic valve. And then on the right, we've placed a new valve within that valve. And then the hemodynamic tracings that you see at the bottom just demonstrate that there was an improvement in that gradient again. And, the valve is working much better than the old previously placed valve. I'm going to turn it over to Dr. Davidson, who's going to talk about our own volume and outcomes at Northwestern Hospital.
Thank you, Chris. That was really an excellent presentation. I think gives a great overview of where the state of the art is in the field today. I just wanted to give you some flavor of what we've been doing at Northwestern. We've been doing these procedures for a number of years. You can see we started back in 2015 with just a handful of these. We've done over 190 thus far, probably over 200 now into this year. This only goes through 2021. Average length of stay is 3 days. And I think what we're most proud of in this is not just the growth in volume, but really the very low mortality rate. Aortic valve, only 1 out of the 100, there were first 100 that were done here, 2 mitrals and 0 on the tricuspid side. So it speaks to the safety of the procedure. And I think, as Chris said, this is not a procedure for everybody, and it does require a multidisciplinary approach to understand whether you're the best candidate for it or not. And there's many factors that go into that, including anatomy, risk of the patient, and other things that we would look over in trying to make what's the best recommendation for you. Next slide. So this is just looking at our total TAVR and aortic valve and valve volume since 2018. Obviously, 2020 was a rough year for cardiovascular patients because of COVID lockdown. A lot of cardiovascular programs and many of the beds in the hospital were utilized by COVID positive patients and reallocated at that point in time. But we have seen good growth coming out of the pandemic. And this year we're looking to hopefully at least match, if not overmatch, what we've done in the past. Next slide. I want to mention on that last slide was that there is a number of research studies going on in this area. Right now, valve and valve procedures are approved for only patients that are high risk for a repeat operation. And so we've been really looking at intermediate risk type patients and trying to understand whether this is a good treatment for them as well. Those data are forthcoming. The early results look very promising. I think the importance going to be is what the durability is. As I think Chris demonstrated nicely, when you start stacking one valve in under another, you're going to create some degree of stenosis just by the kind of the effect of a Russian doll, I think, as he described, where you're making the effective orifice area smaller, even though you're taking the diseased valve out of the equation. But looking at this slide, TAVR, aortic valve and valve versus SAVR distribution, I think this is what's really interesting to me. And when we started with this back in 2018, you can see aortic valve surgery was 93% of patients with aortic stenosis or requiring another valve. And now we've into 2022 and really looking, it's been pretty flat from 2016 on, is about 75%, depending on the year, to 80% of patients are able to be treated with transcatheter-based therapies for aortic stenosis. Now, I think the bicuspid population is unique, and many of those patients have aortopathies that also need treatment. This is not just talk about the aortic regurgitation patients, but really aortic stenosis is 3 out of 4 patients now basically get treated with catheter-based therapies rather than open heart surgery. And this is important to understand the age of the patient, what's the lifetime management of their valvular heart disease. It may be very different from a 60-year-old than it is for an 80-year-old, because the 60-year-old likely one biological valve will not be durable enough to get them through their life. So this is where the informed patient and patient decision-making and advising and shared decision-making is critically important. Next slide. This is just an interesting slide. Back in 2008 to 2011, it was only approved for patients that were high risk or somewhat inoperable. Many of them were inoperable. And as the technology has improved, many now in our 4th generation of some of these technologies, you can see that this has shifted a bit. But interesting enough, the low-risk population seems to be a minority of the group, often owing to that younger patient, maybe do surgery first, and then when they need their second procedure, think about an aortic valve and valve or mitral valve and valve option. Next slide, please. So just to give you an overview of the whole Northwestern Medicine system, we did our first TAVRs in 2008. We were the first in Chicagoland to do that. We expanded to Central DePage Hospital in 2016, and they're on target, I think, to do over about 150 TAVRs this year. We also offer TAVR at McHenry Hospital and then Palos Hospital. We were in the Partner 1, 2, and 3 trials. Those were trials that were pivotal trials that got approval for that high, intermediate, and low-risk patients. As I said earlier, we're in our 4th generation. We've now done over 2,000 transcatheter valve procedures. One of the areas that's really been exciting for us now is working in the tricuspid area with the transcatheter tricuspid valve replacements and repairs, and also in the mitral area where native valves can be treated with either repair or replacement. Not really the subject of today's talk, but a high growth area. And it'll be interesting to see how that plays out over the next few years as far as what proportion of patients still receive surgery versus those that receive catheter-based therapies. But this is a more complex anatomy and will take time, I think, to really achieve the type of 75-25 results that we see now. And it may never quite get to that point. I think this is open for discussion. And look, we want to do what's right for the patients and be able to offer a lot of options depending on risk levels and anatomy. So currently the FDA is approved for all surgical risk for TAVR. As I said, for valve and valve, it's really high risk, and there are trials going on with intermediate risk. And really the long-term outcomes are critically important, whether it be mitral, aortic, tricuspid, valve and valve procedures, as we try to unfold this over the next 5 to 10 years. I think that's our last slide. And it's been a pleasure to speak with everybody here today about what we're doing and how the field's moved. And I think what I'd like you to take away from today is this is one center that does a lot of procedures, but there's many great centers throughout the country that are doing a lot of excellent work as well. And this is really to be informational for people so to help you, inform you on how to manage heart valve disease. Thank you.
So Joy, we are going to go ahead and talk to you. We're so thrilled that you can join us today, and all that we've learned today from Dr. Mehta and Dr. Davidson, you're the living proof. And so let's talk going back to 2014. Joy, you're diagnosed with severe mitral regurgitation. You're told you need open heart surgery. You go through that process. Can you share for the patients what was your experience with open heart surgery? Did you have any challenges, or how did it work for you?
Well, I was very happy to hear how much progress has been made with open heart surgery, because in 2014 I had the full treatment, and it involved quite a bit of pain with breathing and coughing, and of course the scarring that you get to keep your whole life that stays around. But I did recover very, very well. Yeah, I was in recovery for 10 days at a facility, and I was having a pretty good time.
And Joy, you strike me as the type of person. Joy, you strike me as the type of person who always is looking for the silver lining in everything. Did you get back after your first procedure to doing the things you love, like yoga and dancing and all those things?
Yes, I could do everything.
Everything. And so for the folks on the line, Joy's 80 years young. She's been teaching in Chicago for the past 30 years. Your life moves on, but then 2022 comes around. And what did you learn from your doctors?
Well, that first there was a problem, and then with more testing, that it was absolutely necessary that mitral valve be replaced. And I was not happy to go through open heart surgery again. When I was telling you about the difficulty of it, one is the fact that you have to schedule your life to take enough time to recover. Whereas with the new procedure, I took one day off.
One day off, just
one
one
day.
day off. And so let's talk about that, Joy, because it's a new procedure, right? Did you have any concerns that maybe the transcatheter mitral valve and valve reoperation might not be for you? Or did you think, hey, I'm going to go for it?
No, I was just delighted that I was a candidate for it. I didn't realize that being old was part of the reason I got to do it, but oh well, whatever. I never had any worry about it. I just knew that I did not have to go through open heart surgery. And one person I know had the procedure at Northwestern, and I very much trusted the doctors, and I wasn't concerned at all.
And so now let's talk about the procedure, because from the patient perspective, we've heard a lot from the doctors today about the science and the treatment process and all of this, very fantastic innovation. I'm curious to know from the patient perspective, can you share what your experience was like getting a mitral valve replacement reoperation? Like, questions are, how long were you in the hospital? Did you experience any discomfort? Things like that.
Well, I came into the hospital the day of the procedure. Had to wait a little while because the person ahead of me was ahead of me. I had no discomfort at all. I was, of course, fully anesthetized. But I think the reason I'm here, because you asked me to be here before you knew how I spoke and what I looked like. I think the reason I'm here is that the second I woke up, I heard a doctor saying, "That went great." And I guess it did. I did need to go into intensive care for it to be monitored, but I really didn't need. I think I could have just walked home.
Wow. And I'm curious to know, how long were you in the hospital for?
I was there for 2 nights. I was there the night of the procedure, and then just to check on me, I guess I stayed one more night.
Wow. And now let's talk about your life after the procedure. You said you were going to walk home. I think that's a pretty good indicator that things went really well. How are you doing now?
Really well. I kind of hoped to have some change in my life quality right away, but that didn't happen. It took about 4 weeks before I started noticing that I was stronger, that I was more resilient, that I was more involved with things. Since this, I think all who are listening, these heart problems usually go slowly. I did not realize that I was regurgitating away for a while. So I didn't know I needed to get better. And then when I did get better, I thought, this is really nice. This is great. I'm able to do all the things I want to do now.
And really share for the folks how active you are as an 80-year-old. I'm going to ask you some yes and no questions. Are you still teaching?
Yes.
Are you dancing these days?
Yes.
Are you going on walks?
Oh, every day this summer.
That's fantastic. And do you do any form of exercise? I haven't asked you that before, besides walking and dancing.
Yes, I live as an independent person, but in a senior residence, and they offer a lot of activity. So I take a yoga class twice a week, and I take a regular exercise class twice a week, and a lot of other stuff.
Got it.
A lot of other stuff.
So I just want to take another second, Joy, to thank you. I've got probably a big question. It might come up at the end, but why don't we answer it right now? What advice might you have for all the patients on the line? We've got over 270 people on the line. What advice would you have for them if they need a heart valve reoperation?
The first thing is to address it right away. I just sort of, if you have, everyone knows who's here knows that every 2 years you should have a sonogram, and I sort of forgotten about it. So I was 2.5 years before this was detected, and don't do that. Just keep up with your testing so you know that you're you're at the best you can be, and then don't waste any time before you get it corrected.
Great advice, Joy. And I was like you, I skipped 2 years of getting my echocardiogram, and my valve went from moderate to severe. And then I was in a panic over what to do. So great advice. And again, thanks for being with us, Joy. And we can move on now to the questions and answers. This was a great question from Joni, who's on the line. She asks, how big does the valve have to be for the valve and valve procedure? I was told that by this prominent surgeon that there was too small of a cow valve inside of me for my mitral valve. I need a redo at some point, which would be open heart number 4.
Ooh.
Chris, you want to take it, or I can take it?
Yeah, let me address that one. So it depends where we're talking. For the aortic valve, everybody's anatomy is a little bit different. So some people actually have a small annulus where the valve sits, and we size at the time of surgery to see what would be the best size. Now, in the era of transcatheter, with understanding that we may need to do valve and valve procedures in the future, I think surgeons in general are much more cognizant about putting large enough valves in such that in the future, if somebody needs a valve and valve within that bioprosthetic valve, that we could safely do that. And so something that we do that's becoming much more common these days is an aortic root enlargement, which means that if the annulus is too small and we are concerned the valve may be too small, we can actually expand that annulus to some degree in order to accommodate a larger sized valve. Now, in the mitral position, we don't really have the enlargement option, but again, it's the same thing. We're very cognizant about making sure we can put in a large enough sized valve in there. So this is one of the things that we consider when we do this heart valve team multidisciplinary meeting is, we look at the size of the valve, and that may determine one way or the other whether somebody is a suitable transcatheter valve and valve candidate.
Yeah, just to put it succinctly, the larger the valve that's in there, the larger valve we can put in, and then the better the flow is. And we also know that the chances of that valve lasting a longer period of time is better if it's a larger valve than a smaller valve. So this is not a simple question, but one that's also worth discussing with your cardiac surgeon and cardiologist, because you may be able to do it, but the longevity may not be good if it's small, or if it's large, it may be much better. It will be much better.
Next question coming in from Marie, who asks, I had a mitral valve repair 15 years ago, but it's starting to leak again. What are my options if I want to avoid another open heart surgery?
Chris, would you like to take that? Or I'm happy to take it as well, but whatever you like.
Why don't you start, and then I'll fill in.
Okay, well, we didn't talk really about valve and ring procedures, which is what this is describing, because most of the repairs are done with a ring that's left in place. There are various types of rings, which some are more amenable to a valve and ring procedure than others. We often need to do a fair amount of testing, which would include a CAT scan, echocardiography, and shared decision-making with these patients. But this is an area that also is only approved for high risk. Certain rings are very good for it, and it may be an option for you, but a lot more we'd have to know in order to understand whether you're a good candidate and whether this could be offered to you. And Chris, as a cardiac surgeon, obviously understands this very well, what surgical options may be available. And Chris and I obviously do valve and ring procedures together as well.
Right, and to echo a point that Dr. Davidson made, these rings that are used in mitral repairs do come in all different varieties. Some are rigid, some are more flexible, some are complete rings, some are partial bands. So, that's part of what we do in the multidisciplinary meeting is, assess, what type of ring it is, and would that be amenable to a transcatheter procedure? And as a surgeon, we have insight into the different types of rings that are used.
Interesting from Sheldon, my cal valve in the aortic position is starting to fail and I now have an aneurysm. Is there any way transcatheter methods can fix both problems without opening me up?
Chris, this is Chris's expertise, so I'm going to let him absolutely run with this one.
Right. So right now, there is no good endovascular or transcatheter option to address aneurysms. The reason aneurysms are a concern is because if they get big enough, they can lead to aortic dissection or aortic rupture, which are both life-threatening and potentially fatal problems to have. So when we see patients who have an aneurysm and a previous valve that needs to be addressed, those folks tend to need surgery.
Great. And we've got a couple more great questions. I'm going to skip to one about multiple valve in valve. And this comes in from Eli. He's on the call. I'm 94. And 4 years ago, I had TAVR that has worked well, even with slight paravalvular regurgitation. Please comment regarding the likelihood of a successful transcatheter aortic valve in valve procedure if my present valve fails.
Yeah, Chris kind of covered this. I'll maybe pick up on what he already said. I like the Russian doll analogy, and I use that when I'm talking to patients in clinic. First of all, a valve in valve and a valve in TAVR in TAVR is what we usually call it, is something that we do and can be done. Since TAVR has not been around that long, there's not been a ton of experience with it. But once again, a lot of it depends on how large the valve is that's in there already. The larger the valve, the better chance we're going to get a great result with the second valve. I mean, for example, the Sapien comes in 20, 23, 26, and 29 millimeters. For example, if you had a 29 in there, we'd be great about putting a second one in. If you have a 20 in there, it is going to restrict flow to some degree, and longevity of that valve, as well as initial flow, is not going to be quite as good. But it is an option and something you could probably find out more about right now if you just knew what valve size you have in there already. There's some other aspects of this too that have to do with coronary heights and the like, but I won't get into that much detail at this point.
Great. Well, for everybody on the line, thanks so much for being here. We're coming at the end of the hour, but please don't hang up just yet. We want to thank you, all the members of the HeartValveSurgery.com, for being a part of this community event. It is fantastic to get on the line and learn with you about things like the advances in heart valve reoperations. We want to thank Dr. Davidson and Dr. Mehta for taking time away from their very busy practices at Northwestern Medicine. And yes, we have to thank Joy for being our patient spotlight on this webinar. Joy, you're definitely an inspiration to so many people out there on this call who've had not just one, but 2 heart valve procedures and are still having a great time in their life, enjoying yoga, dancing, exercise, and walking. So thanks to all of you for being with us today. Hi, everybody, it's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.